Hello, everyone, and welcome to today's program, Managing the Total Cost of Care, Industry Perspective of Key Challenges Facing Providers, presented by SCIO Health Analytics, hosted by HealthLeaders Media. My name is Jonathan Bees, and I'm the Senior Research Analyst for HealthLeaders Media. I'll be your host for today's webinar. The program will be 60 minutes in length. The first portion of the program is a presentation followed by a question and answer session. Today's program is being recorded. The report that is the basis of today's program was created for and supported by SCIO Health Analytics. Thank them for their support. Now I'd like to introduce today's speakers. With us today is Rose Higgins, President of SCIO Health Analytics, President North America at SCIO Health Analytics. She is responsible for P&L management, including new analytics, services, technology, program and product development, financial planning, operating and capital budgeting, customer relations. Also with us is Kevin Keck, MD, Chief Medical Officer, SCIO Health Analytics. Dr. Keck provides guidance into SCIO Health Analytics clinical analytics strategy. His responsibilities include assessing network quality, and cost challenges for providers, as well as shifting risk profiles. In addition, he provides insights into the translation of those needs to SCIO capabilities and predictive analytics solutions. Finally, I also want to mention that before we get started, I'd like to take a moment to review the web conference platform. First, to ensure that you can see all of the content for the event, please maximize your event window. Second, be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Third, at the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Should you experience any technical difficulties during today's program and need assistance, please click on the Help widget. It has a question mark icon and covers common technical problems. Finally, I also want to mention that an on-demand version of this program will be available approximately one day after the completion of the event. This can be accessed using the same login link that you used for the live program. Also, a copy of today's presentation is available in the Resource List widget, located in the lower left-hand area. What you see on the screen is today's agenda. We'll be going through survey data from the Exploring Cost of Care SCIO Buzz Survey, and then that will be followed with a panel discussion with Rose Higgins and Kevin Keck about total cost of care and their perspectives on total cost of care. And we'll close the agenda with an open Q&A with the audience. The survey was sent out in August 2017, and there were 5 questions. The total number of respondents were 142. And with a base of 142, the margin of error is 8.2% at the 95% confidence interval. And here's a look at the respondent profile. It's a fairly senior audience that we survey, and 36% are in the category of CEO or president, 31% clinical leadership, 15% financial leadership, 11% operations leadership, 4% IT leadership, and 3% marketing leadership. And you can see at the bottom of the slide, those are the definitions of those title groups. The respondent base is also kind of heavily hospital and health systems. So if you combine those first 2 rows, that's 67% of the respondents come from either a hospital or a health system, and then the remaining categories are somewhat lower. So it's a fairly acute care oriented respondent base. And looking at our respondents another way, by bed size, Small category 1 to 199 licensed beds, it's 24% of the base. Mid-size group, 200 and 400, 409 beds is 25%, and 500 plus 29%. And again, you can see it's pretty evenly distributed by size in terms of numbers of beds. However, if you look at numbers of physicians, it's generally larger entities. You can see that 50 plus is 81%. If you look at the number of physicians in the organization. And last demographic profile, it's heavily nonprofit, 70% nonprofit, 30% profit. So here are the results. So this first slide, it's forgive me for this. It's a little bit challenging. We have a lot going on here, and the way to look at this is to first look at the total percents at the end of each bar. So those percents are the aggregated results for first ranked, second ranked, and third ranked. And so taking total response, the top clinical cost driver, according to survey respondents, was pharmacy drug spend, followed by inpatient medical surgical care and chronic disease management. And it's a dead heat, frankly, for the item that comes in the fourth row, specialty care, physician services, at 33%. And so the other aspect of the chart that's of interest is just looking at first ranked. And it may be difficult for you to see the numbers, so I'm going to help you along with some of this. You look at first ranked only. The number one item is inpatient medical surgical care, and that's 28%. So 28% of respondents had that as their first ranked item. And so I'm now going to kind of give you the bar information that you may have trouble seeing. I don't know how it's displaying. So for pharmacy drug spend, it's 17% was first ranked, 23% second ranked, and 14% was third ranked. And looking at inpatient medical surgical care, 28% first ranked, 6% second ranked, 11% third ranked. And chronic disease management is 10% first ranked, 13% second ranked, and 11% third ranked. Lastly, specialty care is 11% for each. The second question the survey asked, please indicate your organization's top roadblock to determining the total cost of care. And the highest response by far for highly fragmented data ownership and data silos at 58%. Lack of resources is significantly lower as a response at 20%, and current view only includes medical and pharmacy costs. So really, fragmented data ownership and data silos, something that is an obstacle for just about everybody in the survey. It's over 50%, and this turns up in other survey research that we've done at HealthLeaders Media, and here's something. This data comes from the HealthLeaders Media Cost and Revenue Strategies survey that we did in June this year. The question asks, what are your organization's 3 biggest barriers to achieving sustainable cost reductions? And these are some of the items that make this so difficult for providers. Lack of data on the true cost of care, 58% is overwhelmingly one item, and there are a variety of reasons why they can't get at that data. But the second item on the list, insufficient integration with care partners, is some of the problem. The ability to share a data across the continuum, challenging for a variety of reasons. I mean, it could be EMR interoperability issues. Variety of different issues kind of driving that. And the third item on the list, lack of technology in place to achieve goals. This is kind of a second tier item. And you can see there's a cluster there with lack of technology in place to achieve goals, lack of patient engagement in their care, and regulatory compliance. I'm always somewhat surprised by lack of patient engagement. You would think most people are heavily engaged in their own care, but there are a variety of reasons for this. This comes up, I think, later in the survey that I'm going to show you some of the reasons behind this, I think. Here is another more survey data from the Cost and Revenue Strategy survey did back in June. This is your organization able to determine the true cost of providing care? And only 6% said that they can do this for all care that they provide. 30% for most care, 51% for some care, and 13% are unable for any care they provide. So they're completely operating in the dark, which is concerning. So another way of looking at this data is to take those first two columns and combine them. So 36% of this group can determine their cost for all care provided or most care provided. And, it's just slightly more than a third of them can do this. So it is a bit of a concern. There are a lot of challenges for providers. Here is the third question in the Exploring Care Costs survey that SCIO sponsored. What type of data is currently not accessible and for your organization's total cost of care effort? And by far, socioeconomic data not accessible. 57% say this. This question is a multi-response question, by the way, so the respondent was able to select more than one item. Post-acute, skilled nursing facility, home health was number 2. Behavioral data, number 3. So the socioeconomic data, there's been a lot of discussion about social determinants data and their potential use in analytics. And I think this is something that we're going to hear more and more about. A lot of people would like to work with that data. There is a connection between patient engagement and these socioeconomic, social determinants circumstances or data. And I think that's where kind of care coordination comes in. It's just areas such as the role of poverty and lack of access to health care, et cetera, et cetera. Question 4 in the Exploring Care Costs survey was what are your organization's top 2 challenges regarding analytics? And number 1 by far, inability of integrating financial and clinical data. Inability of, at 52%, inability of existing health information technology to generate timely analytics insights, that's 51%, and inability of accommodating unstructured data. So the inability of integrating financial and clinical data, this is back to the data silos that we saw back in question 2, fragmented data. Getting those 2 data sets together, challenging for half the organizations that responded to the survey. And then of course the one challenge we hear a lot in our surveys is that timeliness of the analytics insights. Very challenging to kind of turn that around quickly enough to make an impact on outcomes and costs and the like. This slide has data from our Analytics and Healthcare survey. This is from September of this year. And respondents were asked, please select the top 3 data-related challenges your organization expects to face in performing analytics over the next 3 years. I have that top 4 bunch clustered together. And it's a familiar theme, right? It's integrating internal, clinical, and financial data. So it's data silos kind of within your organization, and then integrating external clinical and financial data at 43%. Also a challenge. This is kind of data coming from across the continuum. So there are data silos both internally and externally. Number 3 on the list, establishing and improving EHR interoperability. That probably relates to those first 2 items, particularly the external clinical and financial data. Can't share data, right at the outset. You're already in trouble. And then the 4th item is improving data accuracy. Of course, you're only as good as the your analytics are only as good as the data that's going in. And here is question 5 from the Exploring Care Costs survey. The question is, which of the following would have the greatest impact on patient and financial outcomes for your organization? And top of the list is development of care coordination efforts to close care gaps at 37%, early identification of high-risk, high-cost patients at 31%, and avoiding unnecessary care is much further down the list at 16%. So, development of care coordination efforts to close care gaps, this addresses all sorts of things. Certainly, it would cover some of those patient engagement issues. You have communication efforts across the continuum. There are a variety of ways care coordination can drive impact on patient and financial outcomes. And question 1, chronic disease management, was number 3 for respondents, clinical cost drivers, and that kind of ties in with our second response here of early identification of high-risk, high-cost patients. And there are a lot of numbers out there, but anyway, these types of patients generate very high costs for organizations, and it's obviously a good place to start if you're trying to move the needle on patient and financial. Hey, at this part of the agenda, I'd like to bring in our panel speakers to discuss some of the findings in the survey and the topic overall of managing the total cost of care. One issue that comes up frequently in any discussion of cost of care is transparency. So the first question for the panel is, what are the biggest industry drivers of transparency on total cost of care?
So thank you, Jonathan. This is Rose. I'll start, and Kevin, please feel free to jump in. I think there are several, and we've heard a little bit about it in the results that you've reviewed today, and that is that without transparency and information access, it's very difficult to get a comprehensive view of all of the elements, and how we like to think of it at SCIO is the levers that you need to be able to draw on to improve the overall cost profile and really address total cost of care trend. And so it's important, obviously, to be able to gain access to information, synthesize it in a way then that becomes actionable, and in so doing, have the opportunity to really evaluate how you can then proceed in a systematic way to try to address some of what that information is sharing. And I think, Kevin, if you wouldn't mind, we've talked a lot at SCIO and with our customers about the importance of having access to different levers and different ways in which to think about how do you solve for this challenge, first of accessing the data, but once you've got that data, how do you use that to actually put together a programmatic approach that you can monitor over time and really evaluate if it's being effective?
Yeah, thank you, Rose. In approaching managing the population, the basis is the richness of the analytics that you've got to look at individual patients by their risk what their comorbidities are, what is their socioeconomic status. All those are foundational in approaching what are you going to do to manage the population. It turns out there is a finite number of levers to use in managing the population. The key is deciding based on the data which one will work. And we've got here a comprehensive list of what is available to manage it. The blue bubbles are population health levers, and then the green bubbles are the payment, coding, HCC management, fraud, waste, and abuse. In other words, making sure your claims are being paid correctly and making sure you're getting your deserved top-line revenue in a Medicare environment. But managing the population, we've got these arrayed here on higher dollars to implement, lower dollars to implement, what's going to give you a payoff now, what's going to give you a payoff down the line. And familiar to the inpatient people is inpatient management. Also network steerage and who is in the network, who is contracted. The unit cost is critical. Prior auth is an option, and in these levers, the least popular is prior auth, but it's only one of the array. Benefit design is important, particularly with behavioral economics. In other words, if a patient has lower financial barriers to needed care, higher financial cost to gray zone medicine, that would be an example of benefit design. And then provider management reward, patient education, capitation in certain subsets of the network, and care management, disease management. Most expensive, longest to get a payoff is care management and disease management. Clinical documentation improvement is concomitant with the coding and the accuracy of the data going in. So this is the array that you have, and what the pathway is going to look like is the data set, which has as much as you can put into it. It's got to have per patient, at least claims data, pharmacy data, inpatient, electronic health record. You can get tremendous enhancement by using just populated fields with that, not so hard to dig out as the EHR provider will allow you. Then you have your data mart. The analytics will tell you where are the pressure points, and then what you do is you go to this chart and you ask which of these is going to be most beneficial, or which two or three of these is going to be most beneficial in managing the population. So that's how you use the levers, and I can talk all day about this, but I think I'll stop here.
Okay, good. That's great. All right. Here's another question for the team. Were you surprised to see the results related to the biggest cost drivers in the survey? What would you have expected to see that perhaps you didn't?
Well, certainly I think much of what was captured really did resonate as being oftentimes long-standing problems or challenges. And I think that the emphasis obviously on inpatient medical surgical care is not unexpected. However, beginning to see a transition of those care costs to the care continuum and other settings of care, obviously very dependent on the condition that's being managed or the situation that's being managed. But nonetheless, beginning to see a bit of a movement into the post-acute or the external to acute scenarios would have been something I would have thought might have shown up a little bit here that we didn't really see represented in the data. But one area, obviously, we're hearing a lot about, certainly as we're out talking to colleagues and customers in the industry, pharmaceutical spend is top of mind for many. And within pharmaceutical spend, specialty drug spend, and certainly we're very, very challenged with the opioid crisis that are out there really in every community in America today. So across the board, the pharmaceutical spend is the one that I'm not surprised to see growing. However, I'm a little surprised to see that it actually was underrepresented in comparison to the inpatient and the medical surgical. But overall, I think these are largely aligned with what we hear customers really challenged to address. And then I think as we saw some of the other results, some of the situations that need to be managed through or prioritized to try to address some of this, I think is certainly coming through in the data as well. Kevin, any comments from you?
Yeah, I think there's three things to note. The first is the pharmaceutical spend. Pharmacy is 20 to 25% of the healthcare dollar. Half of that is retail, half of that is specialty, and specialty is growing. I think that's very interesting, seeing that has risen to the top. Second thing is the need for socioeconomic status. Knowing which patients are coming in as self-pay, as Medicaid, as Medicare and commercial, I think is critical in managing an inpatient setting and an integrated delivery system. Optimizing that depends on having the data of, who is self-pay, who is Medicaid, and what can I do when that patient is in the ED about to be admitted to make that the best hospital stay possible and to get that patient the best quality of care. The third thing that struck me was the difficulty that hospitals have or physician groups have getting a full set of data so that the population can be managed. I remember when I was managing a medical group that was in trouble some 20 years ago, the CFO asked me, Kevin, we don't know where to push. Today, with the analytics that are out there, you can know where to push, and that is very helpful and needed in managing the cost, and particularly with risk being pushed to the providers by CMS, little now, more later.
Great. Thank you. That was excellent. Here's another question for the team. It's what do you consider as the market gaps and challenges you see providers face related to understanding total cost of care?
Well, I think we've touched a bit on. I'm sorry, Kevin. Go ahead.
Well, I was going to say that in managing a population, what I find going out in the field is the difficulty understanding what the whole pie is about with healthcare. Usually, there's understanding of a part of it, but not the entirety. And what I find is when we're talking in the field, the concept of wanting to improve quality because that reduces cost sometimes is a new concept. So I think getting to that basic, that what it's about to manage a population and total healthcare costs is improving the quality of the population, and that also includes reducing waste. As waste goes down, quality goes up. And waste would be a diabetic who comes in not taking care of herself and has to have a foot amputation, or a patient with 3 weeks of back pain, not enough conservative therapy, going to a total spine, a spine surgery with hardware. Those are two examples. The other part is understanding that there needs to be initiatives in many areas of the total healthcare spend to improve quality, such as specialty pharmacy, imaging, elective inpatient surgery, and medical inpatient. There needs to be understanding and initiatives in several of these areas in order to manage the total cost of care.
That's great. Excellent. Thank you, Kevin. This question is for Rose. What are key performance strategies for risk-bearing organizations?
Well, I think the primary challenge of a risk-bearing organization is really balancing that cost and quality equation, and Kevin touched on this in terms of those very particular examples. But if we come up a bit and really look at this challenge of managing waste within the organization, there's really two sides of that we need to be looking at. That which is really being done that is perhaps not medically appropriate or necessary, and making sure we have processes in place to evaluate that so that you've got the right level of care being delivered to the patients and at the right cost. Certainly you want to make sure that you're being properly compensated for the care that is being delivered, and part of that is making sure that your analysis of coding accuracy is there, that you're looking at your risk overall for populations and understanding the costs associated with that, and then of course properly documenting so that you can indeed be compensated. And that's important not only for the revenue accuracy and the viability of an organization, of course, but also provides the funds for you to be able to make the investments necessary to manage these kinds of contracts and these value-based arrangements that are coming forward. So doing that in a way where you have a conversation that's transparent and direct with those payer organizations that are out there, again, very reliant on having the necessary data to have that kind of conversation, but similarly being able to prove that there is value being rendered for those benefit dollars and for those care dollars that are flowing into the organization is important to the organization's growth overall. And ultimately, at the end of the day, the real challenge comes down to being efficient in the delivery of the care and certainly making sure that it is effective in terms of achieving the clinical outcomes that are being sought for the patient. I do feel like there is a sort of 360 view of this that needs to be accomplished, and that really begins by having the necessary data that oftentimes happens outside of the borders of the organization's four walls. So if you're taking risk, you certainly have to have information about where care is rendered. Even if it is not being rendered by you, you need to understand that in terms of the context of the total cost of care. That obviously helps you address, if you do have leakage from your network, the opportunity to repatriate and bring that care back to your own door. But at the same time, understanding what are the behaviors that are happening with patients or with providers that are allowing some of that leakage to occur, and are there various steps that can be taken to help you become first of mind, if you will, for the care that needs to be delivered and sought out by your patients, your membership, and certainly seeing that referral pattern improving with providers sending care to you because you're known for the effective, efficient, high-quality care that you're delivering.
Yeah, and also if one is managing risk, one needs to have an infrastructure to help you manage risk. You can't do it by saying to the physicians, let's just do a better job, or saying to the hospital staff, let's just do a better job. There needs to be an infrastructure, and the infrastructure costs dollars. When you're the risk taker, then you want to have return on investment with these dollars. So you need to know that if you're increasing inpatient management with special emphasis on the discharge, that you know that you're going to be decreasing readmissions in the Medicare and Medicaid and commercial books of business, so that you'll know that you're going to have an ROI. And in order to do that, you have to have data that says I can identify 85% of the patients with this surgery type, suppose it's total joint repair, that are going to be readmitted. I can identify 85% of them. If I know that from the data, which is available, then I will know where to put my dollars. And that if I am managing, say, a chronic condition, again, with an expensive licensed person, I want to know that when I close these gaps in care, that my admissions in this Medicaid population, Medicare population, are going to be reduced for diabetes because of this effort, and there needs to be an ROI. The ROI should be 2 to 1 or better. If it's less than 2 to 1, it's still doable. If it's 1 to 1, why bother? So you need to know what you're going to get with the infrastructure. And the infrastructure does include physician leadership to help explain to your physician network why we're doing this and what the outcome's going to be.
That's great. Thank you. Hey, Rose, you mentioned a 360-degree profile. Related to the survey findings around data challenges and the need for growing types of data for value-based care, can you discuss the importance of understanding a 360-degree profile of patient, provider, and claim?
Certainly. And again, it comes down to having that view of what happens outside of your organization. So looking at claim data as being a really rich source of that information. One of the challenges is making sure that you are not looking at this in an isolated manner. And what I mean by that is you want to look at the data in the claim and look across the claim to see what you can learn. But you also want to look across the patient or the member profile that is represented by the claim. So what all is occurring in the particular pattern in which a patient is seeking care? Where are they seeking care? With whom are they seeking care, and what care is being sought? Giving you a perspective on that is really useful in terms of understanding how do you outreach and engage with that patient, how do you drive that behavior in the right direction. And there's a similar vantage point in terms of provider behavior that you want to be able to profile as you look across that claim information, because it again tells you who is delivering the care, where are they delivering the care, how are they billing for the care, is that accurately billed, are there opportunities here to maybe look at it easing administrative burden for the providers that are actually doing a good job all of the time, so that why would you necessarily need to review everything or have the opportunity to allow those folks to have less administrative hurdles when they're trying to get paid and get paid quickly and accurately the first time out. So having the ability to look at data and really evolve it to say that each claim represents a view of an instance in which the person has interacted with the system, but it's another bit of information around both the provider behavior and the patient behavior that's really informative when looked at in totality. And so, for example, we can really take a look at the kinds of impacts around high-cost conditions. And so total cost of care is all about finding that 360 view of the costs that have been incurred against the quality that has been achieved. But you need to be able to understand, and to Kevin's point about return on investment, you need to understand if what you're doing is having the impact that you desire, and particularly in that chronic condition scenario where we saw that represented in the top 5 or so of the areas that were on the minds of the survey respondents as being one of their challenges. One way to do that is when you look across this data, then looking at benchmarks and really understanding how a benchmark can inform and educate how you're doing. So most organizations can look at their own performance year over year and do comparisons internally, but without really looking outside and really looking at normative benchmark and different kinds of benchmark that may be available by population type or line of business, you may be missing an opportunity to really begin to up the performance of the organization. So you can't do that without looking across that 360 view and then looking at that in aggregate and in a comparative manner. And similarly, having the opportunity to look at how risk is actually being profiled in an organization. So we always think about clinical and financial risk, but there's some important parameters here, and I think Kevin's touched on a few of these already, but perhaps, Kevin, you could talk a little bit more about some of these areas.
Yes, and in the go back to the 360 view slide, please. In looking at the in managing a population, you manage each individual. That's how you do it. You know in your population that 0.5% of your population consumes 19% of the resources. We're all familiar with that, and 1% of the population consumes 30% of the resources. It's dramatic. So if you know as much as you can in your data mart about each member in your population, then you can start to draw circles in subsets, and you can say, tell me in my membership that has heart failure in their medical record, show me that subset where they fit on this spectrum, and then that will tell you how do I manage this, and if these are Medicare patients or Medicaid patients or self-pay patients, then the strategy is going to be different based on that socioeconomic and age bucket. So you can take a look at, here are my individuals, my patients with heart failure, with COPD, with diabetes, with seizures, with Parkinson's, with cancer, and then you can tell, do I need case management to manage this? Do I need outbound push text? Do I make an initiative with my medical group? Do I do disease management? How do I manage that? And even the catastrophics are manageable. Your patient, if you're taking risks with a broken neck at age 22 in the rehab center, that patient can be managed to get the best care so that quality goes up, and as quality goes up, then costs go down. And this involves all aspects of the healthcare dollar. It includes the specialty injectables, retail pharmacy, subspecialist visits, imaging, and inpatient medical. I'll just touch a little bit about inpatient elective or ambulatory surgery elective, and a lot of these patients in those services are participating in what's known as gray zone medicine, and an example of gray zone medicine, unfortunately, is an upper endoscopy, taking a look at the esophagus and the stomach. The indications are not very clear when to do that, and so there's wide variations in practice on how often that happens. So the management of the gray zone medicine are strategies such as if a patient has back pain, then it is best to get them to a medical back clinic. If a patient has joint pain, it is best to get them to a medical joint physician, which would be a rheumatologist or an interested sports medicine physician. But managing a population is managing the individual members that you choose to bucket in areas where you can manage it.
Great, Kevin. Thank you.
Yeah, and I think I've answered the next slide, 26. So why don't you ask the next question?
Yeah, I was going to ask you and Rose about if you could provide some exemplars of analytic strategies that are used to manage total cost of care.
I can tell a story of my own experience in a very ill health plan that was hemorrhaging dollars, that in creating disease management programs and managing pharmacy and the various segments of the pie chart resulted in margins. We were a nonprofit that caught the attention of the state we were domiciled in, and the state asked us, why are you making so much money? We think you're withholding care. So, that's, and we explained to the state, and they wanted my health plan to take care of their school teachers and the employees. But those organizations that have physician leadership and put in multiple programs are the ones that do very well. I think Kaiser Permanente is an example of this, where gray zone medicine is very well managed, chronic patients are very well managed, and at discharge from a hospital, there's a well articulated discharge plan.
Yeah, can you think of any other say best practices from organizations that you work with that are leveraging analytics to manage clinical and financial risk and total cost of care?
Well, let me jump in here, Kevin. I think there are many examples where that's the case, and so where, again, organizations, often those that are taking risks today or contemplating taking risks, they're really leveraging analytics to help them predict where their costs are going to be and to help them put together programs that then can affect change as necessary and really focus their attention on the areas that are most important to assure that they can be successful in delivering that quality and effectiveness of care. And so there are many examples in the provider organizations that we spend time with where folks have really spent a lot of time and attention to understanding the cost of the care that they deliver within the organization, and where they have struggled is to get that broader view, that broader vantage point, and being able to help through the use of that acquisition and integration of that data, and then the application of analytics to it that can help them have that predictive perspective is really an area of best practice as we've seen that be adopted. In addition, really broadening the scope of the data that you are using it to inform the programs and the practices that you are having your organization undertake. And so you've heard Kevin mention socioeconomics, and earlier yourself, Jonathan, you talked about the importance of social determinant data. I mean, there is a tremendous amount of richness there to help you tailor your programs and approaches. And it's important to remember that every individual circumstances are different, and that is not just a set of financial characteristics, but how people from an age demographic and what kind of services they have access to and preferences for how they access those services or interact with the system are all part of the kinds of data that are available and can be added into these analyses to give you a much more robust picture of the populations and individuals that you serve. And that's important for a number of reasons, not only because you want to be able to see that level of engagement and that level of, frankly, effective programming, but you also have to deal with the reality of very finite resources and making sure you understand where you can have impact and where you can actually see that engagement actually be improved, helps you tailor where to spend your resources, how to plan for those, what kind of activities can you really focus on and demonstrate success on this year and build a foundation on for the next year and so forth. So this is an important part of getting the job done, is getting access to and really embracing, if you will, these other kinds of data sources, is really adding robustness to your analysis and your predictive capability. As we think about where organizations want to go, many organizations that have had success in assuming risk and managing total cost of care has been because they've actually taken on the desire to identify variation, understand variation, and then to address it. And they do that in a variety of different ways. Lots of folks are focusing in on bringing real-world evidence and best practice to the table. We like to think of that as prescriptive analytics, where you can understand a scenario and then model it and really prescribe, if you will, what the right course of action could and should be, and then, of course, be able to monitor that over time. So getting to that data, really embracing different types of data that can help give you a more robust profile, and then utilizing new analytic strategies and approaches, both predictive and prescriptive, to help instantiate that change and monitor that change over time are really going to be helpful for organizations that are really trying to manage this challenge of total cost of care management.
Great. Thank you very much, Rose. Okay, so at this point in the agenda, we're going to close the panel discussion, and I want to thank our speakers for some great discussion and feedback. Just overall, just excellent stuff. This brings us to the Q&A portion from the audience, and so we would now like to invite attendees to ask live questions of our speakers. To submit a question, click on the Q&A widget at the bottom of your screen. It may already be open and appears on the left side of your screen. Please note that your questions will remain anonymous and will not be viewable by other audience members. And so I'm going to let folks submit some questions here. Here is a question. I'm thinking maybe it's for you, Rose, but Kevin is welcome to weigh in on this as well. The question is, it is difficult to compare true quality and the associated costs across various health systems, even within the same healthcare market, without true risk-adjusted outcomes data. There are some national quality databases that are accomplishing this. They are voluntary. In light of this challenge, how does a payer truly tell what the actual quality of the services are paying for? How does health systems demonstrate their quality so they can be fairly and accurately compared and compensated?
Well, that's just a terrific question, and it's certainly an imperfect world right now in terms of what is available and comparable, but it's important that you go down the path of trying to participate where possible in those types of registries and those kinds of quality assessments. I think certainly everyone is very familiar with the fact that there are standard assessments that are applied industry-wide. And while they sometimes seem like they may be a little bit of a blunt instrument, they really can be real indicators for how to get to a benchmark and attain and improve your performance year over year. And one example would be stars. The dollars associated with the loss of a star is critical in terms of the budget of an organization, and it's a very important part of how you can actually be competitive in a particular marketplace. So I would certainly say that it's important to keep your house in order as it relates to the classics, if you will, your HEDIS reporting, the various kinds of JCO reporting, the information as it relates to STARS ratings, and other types of pay-for-performance metrics that are publicly available or available to subscribers is the kind of information that you want to make sure you're doing a good job of. And then beyond that, your ability to participate in those voluntary programs is very useful, I think, as it relates to organizations that choose not to participate. Those are organizations that may not be considered for different kinds of network strategies, as we see a tremendous importance and focus being placed on narrowing networks and steering towards those networks, and benefit design being aligned with that type of network strategy. These kinds of case studies, if you will, of quality and effective care delivery are going to play part and parcel with some of that network strategy design. And so important to get in there and to play. Don't forget to take care of those foundational building blocks. They are really important and can be very material in terms of your ability to not only attract and retain care, but also to be able to build upon that so you can broaden the scope of care that you are able to deliver and with whom you are able to deliver it.
Yeah, and benchmarks are available with large databases, so best practices can be gleaned. Also, when one is starting on this, one's own benchmark is very important, and that can be compared to what happens next year, and that can be compared to national benchmarks.
Okay, good. Our next question, this will be for the team. On behavioral health, primary care, presumably proactive as well as acute, alternative care, are these areas where disease prevention is addressed? Could you reference briefly the issue of total population chronic disease prevention through community-based health promotion programming?
Well, if we take it from the lens of total cost of care, having a perspective and understanding of what are the costs associated with behavioral health and the various elements of care that are associated with it, whether they're delivered in an acute or community setting, is an important part of the data set that you need. It also is very important to understand the adequacy of available services so that you can maintain the overall integrity of the behavioral health care plan and program as you are working with individuals who have those very specific needs. But I think it's very well understood that in any population management strategy, particularly one that has chronic condition as a foundation, there is always a relationship between that depression and other kinds of behavioral issues that are important to understand and to manage as part of just frankly good comprehensive quality care. And that is one of the challenges oftentimes is getting access to that data and really understanding that not only from how do you program and how do you find ways in which to effectively help support those individuals who need that kind of care delivered in the community or elsewhere. You've got to be able to find ways through the design of your networks and the information that you can share without violating any privacy or other types of regulatory considerations. You need to find ways to understand those costs and those as predictive elements as well in managing a population when you might see the presence or absence of that behavioral health support driving both the cost and the quality of the care in the wrong direction. And of course, ideally making sure that you've got very sound outcomes for that individual as well. So I would say that we still are very much on a journey as it relates to this, but I do believe that the overall discussion that we have with the market and what we understand from our clients is that it is well understood that it's an important part of the equation, and it's a matter of how do you get to all of the underlying details that you need in order to actually have that robust view of what's occurring, understand the implications of the cost that's associated with it, finding ways to get the best possible network put in place to help support both in the acute as well as the community setting that set of needs, and to do so in a way that reduces any kind of stigma associated with that care and obviously enfranchises the individual and supports them depending on what their needs may be. I think we do have our best source of data as it relates to behavioral health through RX data, and so if you have access to that type of pharmaceutical claim data, that's also another way for us to try to bring that in and give us a trigger. I know we have done that analytic work for customers before who struggle to try to find certain populations, and using that RX data as a filter set for us to begin to hone in and to pinpoint and focus. That does give new information oftentimes and is very useful to those organizations who are grappling with this.
And from a clinical standpoint, you want to manage anxiety, depression, substance abuse, chemical dependency, and then the psychoses. Each of these can be defined with analytics. What's problematic if one is a hospital system or the marginalized cohort with thought disorders that jam up the ED. So what you want to do with the analytics is show what portion of your population has these four mental health entities, and then you use the levers to manage it. And like Rose said, it's managed by care settings, pharmacology, and behavioral therapy. The problem of the mental health marginalized patient in the ED is difficult to solve, but there are strategies.
Okay, good. Thank you, Kevin. Unfortunately, we've run out of time, so this is we're coming up to the top of the hour, so it is now concluding the Q&A session of the webinar. In closing, we want you to know that your feedback is very important to us. As seen on screen at the bottom of the current slide, the link to the evaluation. 5 clickable link can be found in the resource list as well as in the program evaluation widget at the bottom of your screen. It will also appear in the slide window at the conclusion of the program. We would greatly appreciate your thoughts on our program today. I would like to thank our speakers again for joining us today, sharing their knowledge on this topic. For our listeners, thank you all for putting aside so much valuable time to watch our program. Hope you found it informative, and we look forward to providing you with other helpful programs in the future. Ladies and gentlemen, this concludes our program. Thank you again for joining us, and have a wonderful day.